Hey,
Hey, Dr. White.
how's it going?
Good. How are you?
Good. You think yesterday was helpful?
Yeah, I think it was great. I think it was like one of the best board reviews that we've had because you combined both. Like there was a lecture format, PowerPoint told us like all the concise information that we needed to know, and you like asked us questions at the end, which got us thinking about the material that you presented. So I think that was like an ideal format.
Okay. We were today, like I have like the second is like the second half is just all questions. So hopefully we can just, piggyback off of yesterday's information.
Sure.
Hopefully it's helpful. Hey, some new faces tonight.
Hey, Eric, are you gonna be at graduation tomorrow?
Mm-hmm. I'm gonna come. I'll be in clinic till 5-ish, so it might be a little late, but
Oh, okay.
I plan to. I'm coming. That's where my graduation was, Embassy Suites.
Were you the last one that had?
Yeah, because when I was a chief, we switched it to the drive-in so we could have one.
Yeah.
Otherwise, there's like really no in-person events. Yeah. Before that, I'm trying to think. So they used to have it at the Hotel Syracuse. So I'm pretty sure my other years, that's where it was, downtown. And I think they got away from that because of parking issues. But
I've never heard of Hotel Syracuse.
it's I'm trying to think what's the bar that's in its basement. Oh, I'm blanking on it now. There's an Irish bar.
Donassis.
Yeah.
Oh, it's
Yeah.
okay.
Yeah. So then they have a restaurant there in the summertime. Pre-COVID, they would have like a summer music series. So it'd be like nice to go for like a drink and a dinner. Like it was an easy walk from work too. And
It's the Marriott now.
it might be a Marriott. But they have like really pretty ornate ballroom. So, but I don't know if it was like between cost and the parking situation for older people was kind of like a nightmare when people would bring their whole families. So
Yeah, I can imagine.
how's it going, Eric?
Not too bad.
Huh.
Like no one here in the med library, just me.
It's 5 o'clock. Sure, like
Yep.
they scatter.
We can start at 5:05 again.
Okay. Let me work on sharing my screen.
Eric, you had a busy day for Code RT or no?
No. No, it's been fine. It's been like nothing.
This week has been like I haven't heard anything.
Yeah, they've been like some small things that were probably caught appropriately early before the RT, thank God.
Oh,
And then there were a lot of sick MICU patients that had code status changes. That's good.
I
awesome.
feel like I saw the coolest stuff when I was the Code RT resident. Like there was a slash trach that was done in IR. I like responded to a code in the cath lab and it was just me and Dr. Chowdhury and like no one else had come there yet. It's just like the coolest. I think it was like one of my favorite rotations.
Okay, I think we can start.
Okay. I feel like we've had like a crop of breast lump questions, but maybe this might be one of the last ones of the bunch. I can start by reading this one. So there's a 44-year-old woman. She's evaluated for a breast lump. She knows 1 week ago. There's no nipple discharge. She's had 2 children, the first at 25. Her menstrual cycles are regular. She has no family members with breast ovarian cancer. She has no other medical problems and takes no medications. On exam, her vitals are normal. Her BMI is 28. Exam of the breast reveals dense tissues bilaterally and no skin changes. A mass is noted in the upper inner area of the right breast, measuring 1.8 centimeters. It is firm, mobile, non-tender with ill-defined margins. There's no evidence of axillary, cervical, or supraclavicular lymphadenopathy, and the remainder of the exam is unremarkable. So they're asking you, which of the following would be the most appropriate diagnostic test to perform next? So like the first part of the question stem, right? They're trying to kind of give you her overall risk profile, you know, late, like early onset menstrual cycles or late childbirthing supposedly carries a higher risk of breast cancer. 25 is not considered late. And then she doesn't have a scary family history. But if you're looking at how they describe the mass, right, the ill-defined margins kind of make you nervous. So this kind of comes back to remembering like the age cutoff that we kind of talked about yesterday as picking the right answer. So what are we thinking?
So with this age, it would be like a mammogram. We didn't really discuss breast MRIs, but the only option here, like that includes mammogram, is both a mammogram and an ultrasound. And
Right.
I'm sure we would do both.
Yeah. And like, so like in the algorithm for, you know, the woman that's less than 30, it's technically an ultrasound followed by mammogram if needed, or like aspiration biopsy. Here, you know, these women, you typically start with a mammogram and it's generally followed up with an ultrasound, but here they're giving you both together, which is probably more realistic of what the test would do to you. Like I said, they're not super unfair. You're not going to do ultrasound alone, but that would be appropriate if she was less than 30. And breast MRI, we really kind of talked about it in the context of BRCA mutations and screening measures. I don't think they really have ever used it in the diagnosis of a breast mass per se. I think, and even people that are diagnosed with breast cancer, you don't see them really going for breast MRI. So I think I'm more of a screening, and a biopsy is like a little bit too invasive, right?
Yeah.
So awesome.
Yeah.
So they gave an answer of like mammogram, and technically that would be right too, because technically the algorithm says mammogram, then ultrasound, but hopefully they wouldn't make you choose those things. Okay, anyone want to read this one?
Yeah, I can read this one. 37-year-old woman was evaluated for contraceptive advice. She's married and has 1-year-old child. The patient describes the conception of this child as an accident because she often missed taking her previous oral contraceptive. Her menstrual periods have resumed irregular, but heavy, and in that regard bothersome to her. Medical history is unremarkable. She drinks a glass of wine every night and smokes a packet of cigarettes daily. She has no other health issues and takes no medications. The result of the pregnancy test performed today is negative. So patient is provide a brief smoking cessation intervention. She's not ready to stop smoking, but will consider it again at a later time. So this patient, she's more than 35 years old and is currently smoking. So estrogen pills are contraindicated in her.
Absolutely.
So,
So that's kind of
so
like that
is
slide I said, like definitely know the contraindications to prescribing things. That's probably what these questions are going to be aimed at. So here she's like greater than 35 and smoking, or maybe they tell you someone's got a migraine with aura, right? And then you're like, okay, she can't use certain ones.
So A and B are out. So it can be progesterone containing IOD versus progesterone only mini pill. As she has bleeding, like heavy menstruation, I feel progesterone containing IOD will also like help with her bleeding.
And what's one other detail that would probably make you not choose D?
Because she often missed taking her oral contraceptive, so she's not probably not compliant.
Right.
So,
And remember with the progesterone only mini pills, not only do they have to take them every day, they have to take them at the same time every day, or they're not
Mhm.
effective. So, I mean, I'm not even sure I would be good at that. Do you know what I mean? Like, and I feel like I have my life somewhat together. So it's just like, I don't see them used too often. They definitely have their place, but IUDs are very, very popular these days. And as long as your patient doesn't have a huge STD risk, I think they're a great option, not user dependent. And like you said, she can't use estrogen. So that's awesome. All right. What about the next one?
I'll read it. A 67-year-old woman is evaluated for urinary incontinence that has progressively worsened over the past 2 years. She experiences incontinence when she laughs or sneezes, but reports no dysuria, hematuria, or loss of continence at night. She has been postmenopausal for 12 years. She had 4 spontaneous term vaginal deliveries between age 32. She has no other problems and takes no medications. On physical exam, all vital signs are normal. BMI is 20. Pelvic examination reveals vaginal atrophy. The remainder of the examination is normal. So this sounds like a stress incontinence, because she experiences it mostly when she laughs or sneezes. It doesn't mention anything about, having incontinence episodes before she reaches the bathroom or feeling like the urge. So which of the following is the most appropriate treatment? I would go with pelvic floor muscle training.
Yeah. And like, and just looking at the options too, I mean, I think sometimes if you're stuck being like, okay, what's the least invasive, the most cost efficient? So, that kind of takes out B, C. I don't think weight loss has shown anything substantial with incontinence. So then you're going down between bladder training and pelvic floor. And then it's just kind of remembering for stress incontinence, Kegels can be very, helpful. And pelvic floor therapy is actually way more involved than Kegels. And it's a great, other countries, after women deliver their babies, automatically get sent to pelvic floor physical therapy to help prevent future incontinence or pelvic pain and all that stuff. I think America's like really behind the times on this, and a lot of women just suffer through incontinence and they're like, oh, I had kids, so this is normal. And that shouldn't be accepted, but this is something you can send your patients to at Upstate. And so, someone that has incontinence and stuff like that, it's a great option, to send them to do. All right. Anyone else want to read the next one? Who's iPhone 54? It's very mysterious.
It's me, Dr. White. I just like going around stuffs like while just listening while I was doing other stuffs as well.
Okay.
32-year-old woman is evaluated for bothersome vaginal discharge of 2 weeks duration. Her last pap smear was obtained 15 months ago and was normal. Nucleic acid amplification test results confirm trichomonas infection. Treatment of the patient is initiated. Which of the following is the most appropriate additional management? So pap testing, test sexual partner for trichomonas, treat sexual partner for trichomonas, no further testing or intervention is necessary. She is 32-year-old, being evaluated for vaginal discharge proven trichomonas.
So this is
So
sorry.
I think we don't need to treat the sexual partner for this. And since he has been already treated, I think no further testing or intervention, but I'm not sure why there's randomly a pap testing mentioned. So
Right. So
yeah.
if we go by the guidelines, does she need a pap smear right now?
no.
Right. Yeah. 15 months ago. So, they don't tell you if her pap
Oh,
was
yeah.
with HPV or not, but it was normal and it was within 3 years. So you can be pretty okay with she doesn't need another pap smear. So then it really comes down to, we know trichomonas is an STD, right? So then it's like, how do you manage this?
I think you're supposed to treat the sexual partner as well. It's one of those.
Yeah. So one, it's like reported to the health department, so the labs usually report it, kind of just same thing with like chlamydia, gonorrhea, syphilis. And then this is actually okay for you to treat the sexual partner. So it's one of those things that I feel like we don't commonly see or do, but we just actually had a patient in the resident clinic with trichomonas. So, but her partner had already been dispensed the treatment by the women's health. The other big thing to remember with trichomonas, really any STD, is that in 3 months duration, usually the CDC guidelines are for you to repeat testing to make sure that the infection is cleared. The problem is, like, I think it's a public health issue. So I think this is why they give doctors some leeway in treating the partner. Just because, like, if you don't do it, it's just kind of going to go back and forth and back and forth. And that's if it's one partner, you know, exclusivity, which a lot of people today are not. So you're trying to squash a bigger issue. And generally, if your patient tests positive for this or has concerns, like, you probably should test them for multiple STDs too. So that could be a possible question too, right? So if someone tests positive for this, besides treating the partner, testing for eradication in 3 months, you'd probably want to test them for other things too, because unfortunately you can have co-infections. Okay, any questions on that? Okay. So what would be like signs on an exam of trichomonas? So like what else might you see in a question stem if they didn't give you the diagnosis?
Strawberry cervix? Yeah. So we're doing.
Yep. Yeah, strawberry cervix. The pH can be somewhat normal, but they might have like green, frothy discharge. So kind of like very different. Generally very symptomatic. I think, a lot of issues with STDs in the female population is that they may be asymptomatic. But this one tends to be like, the patients would be coming forward. All right, I can read this one. So we have a 29-year-old woman who's evaluated during a routine exam. She's asymptomatic. Her last pap smear was obtained 3 years ago and was normal. She completed the HPV vaccine series of 26. Medical and family histories are unremarkable. She takes no medications. So what is appropriate for cervical cancer screening at this time? She's 29. So here's here's another age cutoff that you guys have to know. When do we start HPV testing? Or can you start HPV testing? You don't have to.
At 30, you can do the
30.
code testing every 5 years.
Right, at 30. And just remember, like, even if someone's got the HPV vaccine, that doesn't mean they can't get HPV, right? It doesn't cover all the strains. It does cover a couple of the really high risk ones that, that have been tied to cervical cancer. We don't do it before 30 because it leads to like more invasive testing and can contribute to infertility when usually the infection clears before causing cancer. So here, we're thinking that, so she's not quite 30, so she doesn't need HPV testing yet. So that kind of talks about B and C. What were you gonna say?
No, I was just gonna say she does need a repeat pap because it's been 3 years.
Right, so she does need PAP, so that would be A, right?
Yeah.
Right. So just remember the age, don't start before 21. And then at 30, you can add the HPV. And if you do, and it's normal, and the cytology is normal, you can go 5 years. But, after 30, some physicians still don't add HPV. I find that more rare today, but then you would still be on that 3-year interval.
Yeah.
Okay, who wants to read this one?
I can try. 66-year-old woman is transitioning care after a previous physician retired and undergoes a new patient evaluation. She's asymptomatic. She's unclear when her last pap smear was performed or the results. Medical history is unremarkable and she takes no medication. Physical exam, including vital signs, is normal. Which of the following is the most appropriate cervical cancer screening strategy for this patient? Obtain high-risk HPV testing now. Obtain pap smear and high-risk HPV testing now. Obtain pap smear now. Obtain results of last cervical cancer screening examination. No further testing. I think if we can try to get her previous records, that would be very helpful. That will let us know if we need to do a new pap smear or if she might need a colposcopy or something, or some other procedure, depending on what the previous one was, or if she's even due for her pap smear. So I think we need to get the previous results, would be my guess.
Yep, and I think, that's, once again, like, what's the least invasive test or the most benign thing that kind of fits that criteria if you're just looking at your questions. I don't think we've ever really just obtained HPV testing alone, so that's probably never going to be your answer. And she's above 30, so generally you're probably going to do HPV and pap smears. But when do we typically, or when can you discontinue pap smears?
65.
65, with the caveat being that the people have had like 2 or 3 normal pap smears history before that, right? So she could be done with paps if she's okay with that. But you wouldn't know that unless you obtain the records. So exactly. So 3 is, yeah, the rules are like 3 if you've just done cytologies, and 2 if you have cytologies with HPV that are normal. By 65, you can discontinue screening unless your patient's got like some other crazy history. Okay. All right, let's see. Wants to take a shot at this one.
I can take it. 68-year-old male is evaluated for fever, perineal pain, dysuria, frequency, and intermittent straining that began yesterday. The symptoms began 48 hours after prostate biopsy due to an elevated prostate-specific antigen level detected during routine screening. On physical exam, temperature is 38.7, blood pressure 145/82, pulse rate is 105, respiratory rate is normal, prostate is enlarged, boggy, and it is tended for gentle palpation. No penile discharge and no scrotal pain occurs with palpation. Dipstick urine analysis is positive for leukocyte esterase and nitrates, urine gram-stain reveal gram-negative rods. So he has prostatitis. And it's gram-negative raw, so amoxicillin is not ideal. Ceftriaxone, doxy is not, because it's for like it's usually given for gonococcal and chlamydia combination therapy. So I would go with like trimethoprim sulfamethoxazole. It will have good prostate penetration along with quinolone. So
Yeah,
Bactrim.
exactly. So like, he's obviously just had a prostate biopsy, so it kind of puts him at risk. And then his exam is consistent. Nothing to make you think that there was like something going on with the scrotal contents or anything there itself. And then, he's older than 30. And these men's typically E. coli. Before that, you want to think of gonorrhea, chlamydia, or at least, have that thought going in your brain. But then you have the gram-negative rods. So you're exactly correct that generally you want to use Bactrim or one of the quinolones for the coverage of this, because otherwise other ones don't get into the prostate very well. And then you need an extended course, right? Because it takes some time to eradicate all the bacteria there. Awesome. All right, let's move on. Oh goody, some musculoskeletal stuff.
Bane of my existence. I can do it.
I know.
A 54-year-old man is evaluated for a 6-month history of right shoulder pain. He describes the pain as moderately severe aching that is diffusely localized over the shoulder without radiation to the arm. The pain is constant, although it is worse at night and with any shoulder movement. The pain was insidious in onset and has been progressively worsening. He has had no neurologic or constitutional symptoms. Ibuprofen provides some pain relief. On physical exam, vital signs are normal. Pain and limited range of motion are noted with both active and passive movement in all planes of motion, as is diffuse tenderness over the anterior and posterior areas of the right shoulder. There is no tenderness to palpation of the bony or soft tissue structures, nor is there cervical spine tenderness. There are no neck symptoms or findings. So right shoulder pain, moderately aching, diffusely localized over the shoulder without radiation, constant, worse at night, and with any movement.
I think that's key too. So it's not just active movement, it's passive movement. So it's also like when you're just moving the patient around, which helps a little bit.
Yeah. Okay, so which of the following is the most likely diagnosis? Acromyoclavicular joint degeneration, Um. So that's more like a arthritis.
Hmm. And where's it located?
The right shoulder.
So at the acromioclavicular joint, more
Oh.
anterior, right?
Yeah.
He's having the anterior posterior pain, so probably not that, but it is usually due to arthritis. You're right.
Adhesive capsulitis. So I'm not sure if that would necessarily be like, I'm not sure if that would be like worse at night. And like,
It really can be. I mean, like arthritic pain can be worse at night too, and that's generally the underlying pathology of adhesive capsulitis. They will say generally for this, they will tell you that there's a limited range of motion passively and actively. I generally do see that in question stems.
oh, that's like a frozen shoulder, right? Or,
Yeah, essentially.
yeah,
Yep.
okay.
So you're just kind of, it's like you kind of get calcifications and build up a scar tissue, and so you lose range of motion.
Okay. And then tendonitis. And I could-
He has both anterior and posterior, so I'm not sure tendonitis will cause like tenderness in all all
Yeah.
areas.
You remember the biceps insertion, so it's kind of like up here. So sometimes I feel like, biceps tendonitis doesn't so much make it to test, but sometimes bicep ruptures do. And they have like the Popeye sign, which is like this big hump, and it's like literally because like the tendon detaches. Also super painful. Tendonitis generally has like pinpoint tenderness at the insertion point, which is at the base of like your shoulder and rotator cuff.
Yeah, and then rotator cuff disease. I think he'd have like weakness with rotator cuff disease, which they don't really. Pain in the limited range of motion. Decreased tenderness, the anterior and posterior areas of the right shoulder. I don't, not sure.
Yeah, generally with rotator cuff disease, on the question stems, they're probably going to do more specialized tests to kind of help you localize it and whatnot. I don't.
I would go with adhesive capsulitis.
Yeah, exactly. So I think, and really the key is that loss of range of motion with passive and active exercise, and it's kind of like a diffuse tenderness because the whole shoulder capsule is affected. Where the other pathologies are a little bit more pinpoint.
Yeah,
Makes sense.
I really struggled with that.
Yeah, it's tough because, like I said, like musculoskeletal stuff, it's like not our forte. I think, family medicine spends like time when they're outpatient all the time, like in orthopedic and sports medicine clinics. But I will say, if you're going to practice outpatient medicine, it's like worthwhile to like do
Yeah,
your due diligence for this stuff, because I can't, like, shoulder, obviously back pain. We see a lot of back pain in the resident clinic, but like shoulder, elbows, and knees. I mean, like if I had $1 for every patient that comes with that, I could quit my job. So like being like more comfortable with these, and like we were talking about yesterday, if I suspect rotator cuff stuff, I know they're gonna need an MRI. I really just like shunt them like right to orthopedics, because I know that they're gonna need some sort of higher level evaluation most of the time. Like if it's not a full rotator cuff tear, then they might not need urgent surgery, but typically they do pretty well under orthopedic care, and then the MRIs don't get denied. Okay. What's this one? So we have a 42-year-old male who's evaluated for low back pain that began 4 days ago after he shoveled snow. The pain is mild to moderate in severity and does not radiate. He doesn't have any fevers, leg weakness, night sweats, bowel bladder dysfunction. Ibuprofen lessens the pain, as does a heating pad. He has no history of illicit substance use, and his medical history is unremarkable. He takes no additional medications. On exam, his vitals are normal. You find bilateral lumbar paraspinal muscle tenderness, and the musculoskeletal and neurological exams are otherwise normal. What is the next following most appropriate test to perform next? So basically they elaborate this like really detailed history, right, to tell you that he's a very low risk patient, right? So they give you an inciting incident, he shoveled snow. The pain is not severe. He's not a drug user. He doesn't have fevers. He doesn't have those red flag symptoms, right? Incontinence, saddle anesthesia, no neurological deficits, right? So,
No additional testing is required. I think.
exactly. And I think sometimes it's weird to think that that would be the answer on the test, but it also is like the least invasive, the most cost efficient. Awesome. All right, who wants to tackle this musculoskeletal one?
I can try, but I'm very bad at muscular.
Okay, we're all
44-year-old man is evaluated for right medial elbow pain. Right medial that began 2 months ago with dull ache and gradually worsened. The pain is worse with elbow flexion, and right fourth and fifth fingers are numb. On physical examination, vital signs are normal. Decreased sensation over the volar aspect of the right fourth and fifth fingers are noted, with adduction and abduction weakness of the fingers. Elbow has full range of motion and no notable erythema, swelling, or tenderness. So it's not carpal tunnel because he's having elbow pain, and olecranon bursitis and epicondylitis will have some erythema, like tenderness around the joint. So I think this could be ulnar nerve entrapment because he has weakness and like signs and symptoms of nerve compression.
Yep, exactly. So, when you know it's nerve compression, it kind of takes out, like you said, B and C present a little bit different. And then it's just coming down to knowing where those nerves present. So what would a carpal tunnel patient have?
He will have like the same thing, I think, the lateral, fourth and fifth fingers, tenderness, and tingling and numbness in the lateral aspect of the, medial aspect of the
Yeah,
palm.
exactly. So
Medial.
generally, like some patients, it's more thumb, but it's like thumb, first finger, and half that weird cut off nerve distribution of the third. Commonly, your patients are waking up in the night with like numbness, tingling. They want to shake their hands out. That's actually like a pretty clinically accurate for diagnosing. You can do Tinel sign, but they tell it's positive or something like that. Yeah. So I would say that's another one that's often tested to know those things. Okay, awesome. Who wants to take this one?
I can do this.
Okay.
A 46-year-old man is evaluated for a 2-month history of right anterior knee swelling. The swelling began insidiously and has gradually worsened. It is now the size of a golf ball and interferes with his ability to kneel, which is vital to his job as a carpet layer. The knee is painful only when he kneels. He has no problem with knee motion or stability. He feels well otherwise. On physical examination, vital signs are normal. He has a 4 centimeter swelling on the anterior aspect of his right knee. The overlying skin is erythematous and warm. The knee exhibits full range of motion. There is no medial or lateral joint tenderness, knee joint effusion or laxity with anterior, posterior, valgus, and varus forces. Which of the following is the most appropriate initial management? Activity modification, fluid aspiration, ibuprofen, plain radiography, and serum uric acid measurement. So in this man who has a job of laying carpet, he probably kneels on his knee many times. I would think it could be olecranon. Oh, sorry. Patellar bursitis. Yeah, so I would say activity modification. But to treat, I would go with activity modification for him.
All right. So let's look at the other choices too. So serum, like we look at the serum uric acid measurements, probably never the answer. So even if you thought this was gout, so here the knee, he has full range of motion. It looks like the swelling is the anterior aspect. So the swelling's not actually in the joint space, where gout swelling would be, right?
Yeah.
But even if someone had an acute gout, pulling uric acid when they have acute gout is not reliable, right? It could be completely normal because the gout, like the uric acid crystals, are actually kind of like localized to the area of swelling.
Yep.
So that's never gonna be your answer here. And then so plain radiography is probably not going to show you anything really beyond degenerative bone changes, right? So it's probably not going to be helpful for a fluid collection in front of it. So the big thing is like, what about fluid aspiration? Would you consider it in this patient?
So he doesn't have like any, like, okay, I was gonna say the skin isn't erythematous and warm, but it is. Hence, I think it is important to rule out septic arthritis.
But he doesn't have
Not
rest.
So not necessarily septic arthritis, right? Because it's not in the joint space, but still it could be within the bursitis itself. So, you know, bursitis can be due to repetitive trauma, which is probably most likely because he's a carpet layer, so he's constantly on his knees. But it can be caused by infection as well. So generally in these cases, honestly, with any joint swelling, the answer is probably going to be fluid aspiration. So even if you think it's gout, like very stereotypical gout, you're probably still going to pull the fluid to make sure that you're not missing an infection, just because the consequences of that are disastrous.
Yeah, so wouldn't it be to rule out like a septic joint or?
So this would be just to rule out like an infected bursa, because this swelling is actually not in the joint space. But if there was actually a joint effusion, then it would be you would be looking to rule out septic arthritis. So like if you had a gout presentation, for example, then in that case, like you would see the crystals or you would see signs of infection. Does this always get done? No, right? Because not every like primary care doctor is comfortable doing joint aspirations, and it can be kind of hard to get people in to get stuff aspirated. And sometimes I think we just rely on our clinical judgment. So in reality, like trying supportive care first for something like this, probably not unreasonable in real life, but I think for the testing purposes, if you have a joint area, whether it be bursa or interjoint space, and if there's swelling and effusion, they're probably going to want you to aspirate it. All right. Okay, let's go to the next one. So we have a 28-year-old man who's evaluated in an emergency department for a right ankle sprain that occurred earlier in the day when he was refereeing a soccer game. When running down the field, his right cleat stuck in the turf and his foot rotated laterally. He was able to bear weight immediately after the injury, but he had to leave the game. The ankle has begun to swell, making it difficult for the patient to ambulate. On physical exam, the vital signs are normal. The patient walks with an intelligent gait, although he is able to bear weight. Swelling is present over the anterior and lateral distal leg above the right ankle. Pain is reproduced by both squeezing the leg at mid-calf level and by having the patient cross his right leg over the lateral malleolus resting on the left knee. There's no tenderness to palpation over the malleoli, the navicular bone, or the fifth metatarsal base. So I guess your key information here is like they're going for the Ottawa ankle rules, right? So they're telling you if you need something that would indicate imaging, right? So something that would indicate a fracture. So the first thing that would indicate a fracture is your patient not being able to bear weight, right? So, but he's immediately able to bear weight. Yeah, he's limping around, but he can still bear weight on the foot, which is a good sign. And then when they're palpating the malleoli, the navicular and the fifth metatarsal, and there's not pain there, that's also a good sign that there's not an ankle fracture. So I think with those, we can say we can be comfortable ruling out B, right? What would like an Achilles tendon rupture look like in a patient?
It'll be like pop and pain, acute pain at the ankle.
Yeah.
I think there will be instability, and I think I'm getting confused with the knee thing.
I know we don't really see this test all the time. I think the key is that they're squeezing the leg at the mid-calf level. So it's high and the pain is above the ankle joint. So they're kind of leaning towards one area for an ankle sprain over another. I know they give you swellings present over the anterior and lateral distal leg, but both the swelling is above the ankle joint, which usually indicates a high ankle sprain. So they might necessarily have you identifying the location of the ankle sprain, but I think, this is kind of highlighting the importance of knowing what patients would need imaging. So technically by the Ottawa ankle rules, this patient does not, right? So you would just, you would treat them for their high ankle sprain. Any questions with that? Okay. Yeah. Who would like to try this one?
I can do this one. A 46-year-old woman is evaluated for knee pain. 7 months ago, she underwent sleeve gastrectomy for obesity. Before the procedure, her BMI was 36. She recently initiated a running program to enhance her weight loss and is now experiencing knee pain, which she treats with ibuprofen as needed. Medical history, significant hypertension, obesity, and type 2 diabetes. Medications are atorvastatin, ibuprofen, lisinopril, and metformin. On physical exam, blood pressure is 118/64. Vital signs are normal. Knee examination is remarkable for tenderness with compression of the patella. There is no joint instability or tenderness along the medial or lateral joint lines. Which of the following medications should be discontinued in this patient? So I think the key is that she underwent sleeve gastrectomy, and in that case, you're not supposed to be taking NSAIDs because you don't want any like marginal zone ulcers, etc. So I would DC the ibuprofen.
Right. And like now there were other medications would make sense to discontinue, right? The other ones seem appropriate, right? She's got hypertension, obesity, type 2 diabetes. And her med list is that's kind of like the ideal med list for someone with diabetes, right? She's on the ACE inhibitor, she's on a statin, she's controlled with metformin. Her blood pressure is okay. So I agree. No NSAIDs. And they love this. They love this. The marginal zone ulcers and NSAIDs. So like I said, that the test really does like to focus on things that we can do to hurt patients or things that we do and like identifying that harm for patients. So like I said, when they give you like the med list or whatever, I mean, it's never for no reason. Obviously, that's when they're specifically asking about the meds, but generally they're giving you some sort of clue there. Okay. What about this one?
I can try this one. 38-year-old woman is evaluated for low back pain that began 7 days ago when she bent over to pick a piece of paper. So she describes the pain as moderate aching that is localized to the right lower back. A sharp pain intermittently radiates down the lateral aspect of the right leg. She has not had bowel or bladder dysfunction, fever, leg weakness, night sweats, saddle anesthesia, or weight loss. She has no history of trauma and she doesn't use IV drugs. So, on examination, BMI is 21 and musculoskeletal and neurological examinations are normal. So, lateral aspect down the right leg sounds like sciatica, comprehensive 11 L5S1 level. Tylenol is not the answer. It looks like neuropathic pain. So can we try like duloxetine or something?
So really
Or
the
physical
criteria is like,
therapy.
remember, so they're saying what is the initial treatment? I guess technically everything but oxycodone could technically be used here, right? So this is one of those things where there's not, besides oxy, which we're not going to use for non-cancer pain really on your test, they're not wrong answers. But here they're saying, so it began 7 days ago. She's low risk, so she does nothing indicates that she needs imaging or something scarier is going on,
Yeah.
right? So
Physical therapy or duloxetine? It should be like either.
so the least invasive option would be what?
Physical therapy.
Yeah, so non-pharma. So it could be physical therapy. I mean, it could be massage, it could be stretching, that kind of stuff. I know we're so used to also prescribing a patient's pain medicine too, because our patients demand it essentially. But like if it's non-pharmacologic things or whether they actually said PT, massage, using heat, stretching, just the same way when you have a patient with mental health and there's an answer that includes cognitive behavioral therapy, it's like 99% the answer. So, if you get to a question and you're like, I have no idea, half the time or more than half the time, you could probably get the right answer by choosing the most minimal option. One is a little bit harder than others because none of these are technically harmful.
Sounded like nerve pain to me, so I thought duloxetine might can also help, but the first option would be like non-pharmacological.
Yeah, and it certainly is an option, right? So, you know, that gabapentin and whatnot. I think the test is big on just like a stepwise process. So, you know, just like with the breast mass, like, did you do an ultrasound first? Did you do a mammogram first? And it's hard because in real life, we do all of the things together or like you do all of the labs together, you know what I mean? Because you know your patient's not going to go back to the lab 50 times. But on the test, they're like, no, you just do this lab. And then if that's abnormal, you do this lab, right? Okay. What about this one? So a 66-year-old woman who's evaluated during a follow-up visit for a 5-year history of chronic autoimmune pancreatitis. She has constant severe aching mid-abdominal pain that radiates to the back. Her only surgical option is pancreaticojejunostomy, a procedure that she's not ready to accept. She has previously tried several TCAs, venlafaxine, gabapentin, oral morphine, and tramadol. The fentanyl patch was substituted for oral morphine during a recent hospitalization. And over the past 6 weeks, she has noted reduced pain and improved function with its use. She lives with her husband and oldest daughter at her home. She does not smoke, drink alcohol, or use illicit drugs. Her only medications are a fentanyl patch, that's 25 micrograms every 72 hours, prednisone, and pancreatic enzyme replacement. On physical exam, the patient is frail. Vital signs are normal, BMI is 21, abdomen scaphoid, bowel sounds are present, mid-epigastric palpation reveals tenderness. Which of the following is the most appropriate next step? So besides like fentanyl, her med list is not bad. Like this is like a med list we'll never see in real life in a patient with chronic pancreatitis. But so like, and she has no high risk behaviors with a controlled substance, right? So she's not drinking alcohol, she's not using drugs. She doesn't look like she has an addictive personality. It's like kind of what they're pointing at here. So if we look at the answer choices, do we want to add lorazepam, provide naloxone, and provide caregiver education on its use? Recommend weekly nursing visits before each opioid prescription, or to switch the fentanyl patch to short-acting hydromorphone or Dilaudid? What are our thoughts?
So I did a previous question on MixApp, and essentially that was focused on avoiding opioids for patients with chronic pancreatitis.
Avoiding opioids?
Yeah, but
Yeah.
that doesn't seem to be any of the options here.
No, and I think the point is that they look like they exhausted all non-opioid options.
Yeah.
Because this is like super hard. Honestly, even with opioids, I find in real life this pain is super hard to control. I think the best relief I've had some patients get were from actual nerve blocks or nerve ablations to the celiac plexus. But beyond that, I mean, it's pretty awful. But so, I mean, we're not going to add another controlled substance. It's probably never going to be the answer. So like for A, unless you have a palliative care patient, you're probably not going to be adding lorazepam.
Yeah, I would probably pick B, prescribe naloxone. However, that doesn't really address that she still has constant severe pain, but none of the other options really address that first.
Yeah.
So like
But-
I read in the peak modules recently that for patients with severe pain, we have to monitor them constantly, like close outpatient follow-up. I mean, so can it be like C2, like weekly close monitoring for severe pain? Because
Well-
that's what was mentioned in the peak module. We have to monitor them weekly before increasing opiates and see how she does on the current treatment.
Yeah, I mean, you want to monitor them closely, but the whole point here is she's probably not opioid naive, right?
Yeah.
So, and you're never going to put an opioid naive patient on a fentanyl patch anyways. That could be another question, right? So you don't just jump to a fentanyl patch, you know, you're going to get your patient there. They do need close monitoring, but a weekly nursing visit before you dispense each script is probably not practical, as long as your patient's like appropriately using them, and hopefully you're only prescribing them to patients that are going to use them. But I think a big thing here is about anyone that you prescribe opioids to should also be prescribed naloxone. It's like, I'm sure you guys see the warnings coming up too when you're renewing scripts, whatever, that like literally they want you to dispense it every time you send the script in, even on patients where their dose hasn't changed for years and years. It's a big push because obviously opioid overdoses are a huge problem. So that, and I would say the other big thing with opioids is you're prescribing them. The other things is making sure they're on a bowel regimen. I think the board really likes to point that out too. So like you put someone on oxy, you also give them a bowel regimen. You also give them a prescription for naloxone. They might also go to the point where like they should have a controlled substance agreement, you know, and so I know we don't have a lot of controlled substance patients in our resident clinic for good reason, but you know, they should sign a contract that goes over the expectations and what's allowed and what's not allowed and what would warrant immediate termination of the script, as well as routine drug testing to make sure that they're using it appropriately. So when you're drug testing, you're not just testing for other illicit substances, you're actually testing that the substance you're using is showing up, AKA they're not just like filling the script and selling it, right? Obviously there's, you know, people trying to get around that and whatnot, but generally by dispense records and whatnot. And nowadays the opioid prescribing is so strict that, you know, it has to be sent in electronically. There's no more, they can bring a paper script. There's no more, you can call in or alter a dose over the phone. So it has to be electronically sent. You can only do a month at a time. You know, we have the iStop, we have all these regulations in place. So generally these questions are going to be going at some sort of regulation. So, but I think ideally, unless it's cancer related pain, we try not to use opioids. Although if you look at the guidelines for osteoarthritis, it is indicated for bad arthritic pains that fail conservative therapies, Tylenol and NSAIDs, or if patients can't take those. And there was a recent paper that showed that duloxetine was the same as placebo for arthritic pain. So I know we use it and we try to convince patients at work, but that's technically in the guidelines. That won't be the answer on your test though. Okay. Go to the next one. Who wants to do this one?
I can do it. 59-year-old woman is evaluated during a follow-up visit for mouth pain of 2 years duration. I can't do this. Okay. Her mouth pain was previously localized to the tongue and floor of the mouth. However, it is now diffuse, burning, and constant. The pain has also worsened over the past year, despite continued dosage escalation of a transdermal fentanyl patch and oral hydromorphone. She has no pain with swallowing. Medical history is significant for squamous cell carcinoma of the tongue, treated with chemotherapy and radiation therapy. Her treatment course was complicated by severe mucositis. She has been without evidence of disease for the past 2 years. On physical exam, vital signs are normal. Patient is alert, oriented, but inattentive and slow to answer questions. Reflexes are exaggerated in the upper and lower extremities, and myoclonic jerking of the legs and clonus of the ankles are noted. Strength is normal. Mouth examination reveals erythematous oral mucosa with no focal areas of erosion or masses. CT scan of head and neck shows no evidence of recurrent disease. Which of the following is the most likely diagnosis? So malingering, opioid-induced hyperalgesia, opioid withdrawal, pseudo-addiction. So I do not think this patient is in opioid withdrawal. That would be more some abdominal pain, yawning, stuff like that. No.
Yep.
Patient appears inattentive, slow to answer questions, almost obtunded, a little stuporous from opioids. So they are getting opioids. I don't think the patient's malingering, possibly opioid-induced hyperalgesia, because despite continuously escalating doses of opioid medications, the pain appears to be getting worse. So my thought would be this would be opioid-induced hyperalgesia.
Yeah. Absolutely. And also you can notice like that the character of pain has changed, right? So the pain went from actually the area of her pathology to now it's like body wide, diffuse, burning, constant, right? So you can see this like change in pain or it become more like all, you know, just all over or not localized to the pathology. I don't know if any of you guys have been in Dr. Johnson's clinic when we used to rotate there, but they do that the cold test where they put the patient's hand in water, and these patients have increased sensitivity to pain, so they're not able to hold their hand in cold water. So like most of us, like, you stick your hand in ice cold water, you're like, well, this is not fun, but I can hold my hand there, right? These patients, like, they cannot tolerate the pain. It's excruciating. So unfortunately, like the longer and higher doses you go up on opioids, they're going to need increasing doses over time, and then they become more sensitized to pain. So it's just like this negative cycle. And I know we try to explain that to patients when we start them on opioids. But it's a hard thing to get around. So like, chronic opioids over time are probably going to worsen their pain or their tolerance to pain in general, unless they're able to stay at like super low doses. Anyone have questions on that? Yes, I really haven't seen this too much in like real life. Okay, so we have a 24-year-old man who's evaluated for a 6-week history of severely depressed mood and loss of interest in work, family, or friends. So for depression, right, he's been asked to 2 weeks, and he includes anhedonia, so that's part of the diagnosis of depression. So maybe that's it. During this time period, he's been sleeping more than usual, up to 11 hours per day, but still feels like he has no energy. He feels he's a burden to his family, coworkers, and admits to sometimes thinking about suicide. He had similar symptoms 2 years ago, for which he was treated with escitalopram. He remained on this therapy for only 2 weeks because the symptoms rapidly abated and he had a surge of energy. 1 year ago, he had a 4-week period during which he had similar increase in energy level. During that time, he slept only 4 hours per night, decided that he would become a competitive triathlete. He used most of his money to start a boot camp fitness business, which closed within 2 months. He has never had hallucinations. He takes no medications, and he doesn't use alcohol or drugs. So what do we think? What do you say?
Bipolar.
Right. I wish in real life picking up on mania was this easy. I mean, technically, hopefully the patient can tell you about these episodes where they felt really, really great. But I think bipolar 2 can kind of sneak under the radar because like hypomania doesn't have to be so like overtly obvious. But so, you rule, so this isn't, anyway, he doesn't sound anxious. Schizophrenia, he's not hallucinating or, have disorganized thought. Generally, there's some disorder in their day-to-day functioning and social interactions as well that you would see with that. And it's not depression alone because he's showing the mania. And these people should not just be put on an SSRI, as you all know. So they would either start them with a mood stabilizer. You can use lithium. Long-term lithium, not so great because of possible side effects. It just has to be closely monitored. Or you can use other neuroleptics or atypical antipsychotics. And then you can also, if you're doing that, you can start concurrently with an SSRI, or some people wait a little bit to put them on it. Okay. Who wants to do this one?
I can do this. A 31-year-old man is evaluated during a follow-up visit for depression. He previously experienced 2 episodes of major depressive disorder that were effectively treated with fluoxetine. 3 months ago, he presented with recurrent symptoms of depression. His PHQ-9 score was 14, indicating moderate depression. Fluoxetine was initiated and up-titrated to an effective dose. The patient now reports significant improvement in his symptoms. His PHQ-9 score is 6, indicating mild depression. He reports no adverse effects of the medication. So they didn't mention, 3 months. Okay, it is after 3 months. Which of the following is the most appropriate next step in management? Complete 8 months of fluoxetine therapy, complete 8 months of fluoxetine, then switch to bupropion for long-term maintenance therapy, continue fluoxetine as long-term maintenance therapy. So we cannot discontinue fluoxetine because he has history of 2 episodes of major depressive disorder. So I don't think we need to switch to bupropion for long-term maintenance because he's responsive to fluoxetine.
Right.
So continue fluoxetine as a long-term maintenance therapy because of his history of previous depressive episodes like major depression, because he has more than 2 episodes, more than or equal to 1 severe major depressive disorder.
Yeah, so generally the guidelines say like if someone's had three or more, so this is his third episode, then they should consider staying on indefinitely. I think a lot of our patients just stay on indefinitely anyway, because once they feel better, it's kind of like they don't necessarily want to come off. But generally speaking, if you have, someone with depression, it's well controlled for like 6 to 8 months, you could consider tapering down and taking them off and see how they do. If they have a recurrent episode, generally the guidance is that they stay on it longer than they did previously to see if you can put it into remission. But then once they've had like multiple episodes, pretty clear that you should just keep people on it. Interestingly, we recently like met with a psychiatrist, and I feel like their guidance with SSRIs has changed a lot for depression and anxiety. So, they used to say like, start a dose, low dose, you wait 4 to 6 weeks for it to reach maximum efficacy. And then you kind of reevaluate and see what they do. Now their stance is more like, if you don't see significant improvement within like 2 weeks, they feel that med's really not going to work for the person, and they're rapidly escalating them, which I find just very interesting, because I have a lot of patients in my practice that have responded really well to low doses that I probably would have missed if I rapidly ramped them up, which is very interesting, right? I don't know if you guys have seen that in any of your patients, but they're not waiting like 4 weeks to start switching meds. They're going like 1 to 2 weeks, and if they're not seeing a significant response, they just like pop something else. And after like 1 or 2 SSRIs, they like kind of quit the category altogether. So obviously that's not going to be on your test, but I just thought it was very interesting because it's like so different than what we learned and like what we practiced really. All right, so now we have some eating disorder questions.
I can do this. A 17-year-old girl is seen for a health maintenance evaluation. She reports no health issues. In discussing dietary habits, she states that she frequently eats very large amounts of food until she is uncomfortably full. These episodes have occurred at least twice per week for the past year. During them, she feels a loss of control over her eating and guilt about her overconsumption. She often eats large amounts of food despite not being hungry, and she prefers eating alone because she is embarrassed of her eating. She does not take laxatives or induce vomiting after such episodes. She rarely exercises. BMI is 30. Okay, so she is binging and her BMI is, greater than 18. She's not vomiting or taking laxatives. So I would rule out anorexia because her BMI is greater than 18.
Yep.
She's not vomiting or taking laxatives, so that helps me rule out bulimia nervosa. And I mean, overeating, yes, but she feels like a loss of control over her eating and guilt about her consumption. So that's not necessarily just overeating. I would go with binge eating disorder in this case.
Yep, exactly. I think your reasoning is spot on. And the big thing, like I said, when I was going over the fast points for this stuff, look at the BMI, because like right away, if they don't have a abnormally low BMI, it's not anorexia. So then you're really just kind of coming down to like, do they have that binge purge? One of them, it can be both or one or the other behavior. It definitely has to be impacting their life, changing and how they have some form of body dysmorphia usually for bulimia or anorexia. But here she's mostly just binge eating, overeating. I don't even know how they would necessarily define that. I don't know if we could really medically categorize that other than like someone that's obese due to excessive calorie consumption.
Yeah.
All right. Anyone want to do this one?
Yeah, I can do it. Oh, no worries. Go ahead.
All right. So a 38-year-old man is evaluated for an 8-week history of insomnia and irritability. He previously saw another physician in the practice whom he described as a terrible doctor. He was treated for depression for several years and has a history of several low lethality suicide attempts, usually related to interpersonal conflict. He also reports having turbulent relationships with his parents and siblings. During the appointment, he makes several comments about your bedside manners and calls you the best doctor he has ever had. In discussing his symptoms, he attributes many of them to the breakup with his previous girlfriend. After the breakup, he engaged in a 3-day drinking and gambling binge. The patient says he is doing great now because he is in a new relationship with the perfect woman. So, which of the following is the most likely diagnosis? This doesn't sound like bipolar. He's not manic. Generalized, I don't see any significant anxiety or difficult with functioning. He is definitely not histrionic. This is borderline personality disorder, pretty typical splitting. And this is one person's good,
Like
one
everything's
person's
great or everything's terrible. They're, turbulent relationships, interpersonal conflicts. A lot of behavioral disorders or personality disorders don't always are not easily diagnosed 1 or 2 visits. They're really kind of things you observe over time, unless it's so blatantly obvious like this is. Incredibly hard to treat. Like your borderline patients are probably going to be some of your hardest patients you'll ever deal with. What's recommended for them is cognitive behavioral therapy. There's not really a medication that really improves their personality, but you hope to improve their insight. And in that sense, coming to tackle it, but very difficult. And then common with other psychiatric illnesses. So it's not like your borderline person couldn't have depression or couldn't have anxiety, but here they're really focusing on the personality disorder. What's histrionic personality disorder?
What is it?
Yeah.
Yeah, it's one of the cluster B personality disorders in which they seek a lot of attention. They do go out of their way to make themselves look good. They might be flirtatious.
Yeah.
I think it's
Like
mainly
very dramatic.
Yeah, dramatic. Yeah.
Yeah, very
I think
dramatic.
that they'll have a lot of suicide attempts too. For
Yeah.
borderline, there's also kind of points towards the borderline.
Yep. And then the low lethality, it's almost like they're calling for attention, kind of thing. So I think sometimes, they do the suicide attempts, but hopefully maybe the intention that they don't really want to kill themselves. They just kind of, it's just how they're calling attention to some sort of relationship issue. These people commonly go through a lot of doctors. Okay. So I'm going to say so if you see cognitive behavioral therapy as an answer choice, 90% of the time it's the answer. So we can read the question, but that's probably going to be the answer. So we have a 49-year-old man. He's evaluated for a 2-year history of poor sleep with associated daytime fatigue and sleepiness that often interfere with his performance at work. He recorded a sleep diary, which reveals difficulty with sleep initiation and multiple awakenings throughout the night. He has no other physical symptoms that affect his sleep. His partner does not notice him snoring or gasping, and his physical exam, including vitals, are normal. So what would you tell him to do? So insomnia, right? What's the first line treatment for insomnia?
CBT.
Yep, CBT. So, bedtime hygiene, CBT. Can you find it in real life? No, but it's a test answer. You're never going to tell a patient to take Benadryl to sleep. So that will never be the answer. Mirtazapine, you're not going to use it for sleep alone, right? So if you have a depressed patient who also has trouble sleeping, then it can be helpful. I don't think they're ever going to have you choose Ambien. And then melatonin generally would be the answer for a shift work or sleep disorder, right? Okay. Who wants to do this one?
A 63-year-old woman is evaluated in the ED after an unwitnessed syncopal event. She recalls feeling a sensation of warmth and generalized weakness prior to the event, but had no chest pain, dyspnea, or palpitations. A medical history is significant for hypertension, hyperlipidemia, and carotid artery stenosis treated with endarterectomy. Medications are lisinopril, hydrochlorothiazide, atorvastatin, and aspirin. Vital signs and screening, cardiovascular, and neurologic exams are normal. Which of the following tests should be included in the initial evaluation of this patient? So she did have some prodromal symptoms. like warmth and generalized weakness, which wouldn't be the case if this was a cardiac syncope. They would just kind of like drop on the floor.
Right.
So, okay, so that helps us kind of rule out, that helps us rule out A, and then B, I don't know why you would get that anyway, so, that doesn't look like she's in heart failure. We're not worried about like an MI with, she has no chest pain, no dyspnea. So between C and D, I would start with D, get an EKG and orthostatic blood pressure measure.
Right, and so you remember that key point that for anyone with syncope, that the only two indicated tests absolutely are EKG and orthostatic blood pressure measurement. Everything beyond that is not really clinically indicated unless your history strongly points to something of that etiology. So we throw everything in the kitchen sink at these patients that come with syncope, they get admitted for OBS, but truthfully, like probably like 90% of them don't need that. This case is probably vasovagal, right? She had the prodromal symptoms. So even though she has like vascular disease in her history, so the common things are common. So, I mean, she doesn't have anything, as long as her EKG is okay. And, you know, the history is like consistent with vasovagal. Technically, you really don't have to do anything beyond that. It's different if you hear a murmur or, you know, they like present with like this like neurological deficit, so you're thinking there's a stroke or something like that. Yeah, and then like BNP and like troponin measurement obviously gets done in real life, but not really indicated here. But you know, if you had any concern for an MI, hopefully your patient would be symptomatic beyond syncope and their EKG maybe not normal. Okay, what about this one?
I can do this one. 78-year-old man is evaluated in the ED for 1-day history of worsening dizziness. The patient described dizziness as a room spinning sensation, notes that he has some accompanying nausea and imbalance. He reports no other symptoms. Medical history is notable for hypertension, hyperlipidemia, type 2 diabetes. Medications are aspirin, lisinopril, atorvastatin, and metformin. Physical exam, blood pressure is elevated 172/88. Vital signs are normal. Other vital signs are normal. The patient has difficulty in tandem walking. With extraocular movement testing, the patient has vertical nystagmus. Neurological examination is otherwise non-focal without altered mentation. So he has high blood pressure and difficulty with tandem walking. Vertical nystagmus is suggestive of central vertigo. So I would go with MRI of brain to see if he has any. I'm not able to like decide between CT and MRI. I would go with MRI because it could be. There are no acute signs or some.
Well, so
I would go with MRI.
What part of the brain, if a patient has a stroke, causes vertigo generally?
Cerebellum.
Right. And so, and what imaging is preferred for cerebellar imaging?
MRI.
MRI, right? And so that's why in this question you would go to an MRI. So a lot of times, you know, like CT is obviously cheaper, faster. This patient might still get a CT to rule out a bleed, right? But the truth is that the posterior fossa of the brain has a lot of interference from the bone on a CT. So even if the patient had a stroke, you might not see it. And in an acute setting, right, a stroke might not even show up on a CT, but it is going to show up on the MRI, but it does take a little bit longer. But you definitely picked up on all the red flags here, right? So first of all, he's older. The older patients, like they've almost all had vascular disease in the past. So, you know, you're worried about a more central cause, but he has problems walking. He's got vertical nystagmus. Vertical nystagmus is never going to be peripheral. All right. Awesome. These patients can also present with like autonomic dysfunction, like flushing, high blood pressure, all that kind of stuff, because there's like a lot of nerves that are running through the cerebellum and in the, you know, the posterior brain there. These patients have to be monitored at least in a neurological step down, if not in ICU, because they can have significant swelling. And there's like, obviously the brain in the skull itself doesn't have a lot of room, but that area especially doesn't have a lot of room. So they have to be monitored very closely. All right. So We have a 58-year-old man who's admitted to the hospital for a 2-week history of worsening constipation. He has end-stage heart failure, so NYHA class 4 and stage 3 CKD. He's on bisoprolol, furosemide, losartan, spironolactone, hydromorphine for dyspnea, palliation, bisacodyl, lactulose, senna, docustate, and a tap water enema. On physical exam, his respiratory rate is 20. His other vitals are normal. His oxygen is 92 on room air. His cardiac exam reveals an S3 JVD and peripheral edema. Crackles are auscultated at the lung bases. Moderate abdominal distension is noted with tenderness of palpation. So which of the following is the most appropriate treatment of this patient's constipation? What are we thinking? So he's on bisacodyl, lactulose, senna, docustate, and has a tap water enema available.
So,
What's the primary driver of his constipation?
regular bowel. Sorry.
I was gonna say, what do we think the primary driver of his
Yeah,
constipation?
so
here?
he's already tried all the regular, bowel regimen stuff. Probably his opioid use is what's causing his constipation.
Right.
As far as I remember, the first line for opioid-induced constipation is still like the regular bowel regimen, and then if that doesn't work, then you want to do methyl naltrexone. So we'll go with B here.
Exactly. I don't really see A used that often. And then he's already on both stool softeners and laxatives. So like the C doesn't make sense. And we don't really use, I feel like, sodium phosphate enemas very much, especially someone that might have easily get electrolyte abnormalities. So here, he's undilaudid. This is probably that would be the most helpful for him. Awesome. Okay, so let's see. We have a 42-year-old woman who's approaching discharge from the hospital for alcohol withdrawal. She's had severe alcohol use disorder for several years, but says she is willing to do whatever it takes to quit. Her history is also significant for hypertension and CKD, and she's on amlodipine and chlorthalidone. On physical exam, the vital signs in her exam is normal. The CBC and CMP are normal. The estimated GFR is 50. So which of the following is the most appropriate pharmacologic regimens? This is an interesting question because technically this is like the answer to this is like guideline driven for helping prevent hospital readmissions. It's supposed to be very helpful for alcoholics, but honestly, I don't see it done a lot.
Maybe not naltrexone.
Yeah. So that is what is like, it shows this like substantial decrease in readmissions. I can't personally think of any like withdrawal patient that I've seen leave on this. I don't know if any of you have seen them, but that is what the guideline driven therapy is. I really don't see disulfiram used. It's more kind of like an outpatient setting, at least. I would have to double check for like chlordiazepoxide, your patient's not actively in withdrawal, and that's a very long acting benzodiazepine. So for someone with a reduced GFR, probably not the greatest option. In these patients, we tend to, use Ativan a lot of the time. So I think it's just one of those things to know, the use of naltrexone that technically we probably should be using a lot more than we do. Have any of you used it?
No.
I have seen some patients who are on naltrexone, but I don't know whether it is for alcohol withdrawal or not, like at home. So
Yeah.
probably, I don't know at that time, that could be the reason why I don't pick up, but I have seen some patients who are on naltrexone at
Yeah.
home.
Certainly for something for you guys to consider the next time you discharge an alcohol withdrawal patient. So. Okay, who wants to do this one?
A 43-year-old woman is evaluated during a follow-up appointment for obesity. She has been following a reduced calorie, low-fat diet and participating in a 45-minute aerobic exercise class 3 times weekly for the past 6 months. After her last follow-up, appointment 1 month ago. She added 30 minutes of brisk walking on the weekend to her exercise regimen. She brings a food diary and weekly weight records to her appointment. She lost an average of half a pound per week over the first 3 to 4 weeks, but her weight loss tapered thereafter, and her weight has increased by 1 pound since her last visit. The total amount of weight lost over the past 3 months is 6 pounds, or 3% of her original weight. The patient reports that she is unable to achieve the calorie reduction recommended, stating that she is hungry all the time. Medical history is significant for type 2 diabetes and hypertension. Medications are amlodipine, lisinopril, and metformin. On physical examination, blood pressure is 141 over 92, BMI is 31. The remainder of the examination is unremarkable. Which of the following is the most appropriate next step in treatment? So it looks like she's really tried all of the, non-pharmacologic, like the lifestyle modification stuff.
Yeah.
So she would qualify for bariatric surgery at this point.
Don't think that BMI would qualify
Yeah,
for
BMI is too low for it.
Yeah. So what are the BMIs usually we usually go for bariatric surgery?
I think 40.
40 or
38.
35 or 40.
so it's 35 if they have like medical comorbidities, which she does, but her BMI is not quite 35, or 40 just by itself. So that's probably why A is not the answer.
Yeah, so then I would, she said that she can't do the calorie reduction, so I'm not sure if switching to a very low calorie is appropriate or safe for her. I would try the GLP-1 agonist.
Yeah. And those are, so that there's one of the options, right? So she's, if they put like phentermine here, she's probably not a candidate for that because her blood pressure is technically not the best controlled. But you can use phentermine in people with hypertension as long as it's well controlled, and it's actually pretty well tolerated. It's really only studied for 3 months therapy. The GLP-1s really haven't been studied at length, so we really can't guide patients once they've hit their goal weight. Like, do you try tapering down to a maintenance dose? Do you try weaning them off? I think the jury's still out on what exactly to do. And then obviously we talked about, like orlistat, topiramate, those are other options too. But I think the test is really going to like the GLPs because they're like the new up and coming and obviously super popular thing.
Yeah.
She's already like on a she's already on a reduced calorie, low fat diet. She's already doing exercise like you pointed out. So she's done all the things. Like if she hadn't done that stuff, then dietary exercise modifications would obviously be your first thing that you would try. And then in reality, will her insurance approve liraglutide? I don't know.
Oh, probably not.
It depends. Okay, so then we have a 45-year-old woman who's evaluated for a 2-month history of bothersome lower extremity edema. The edema does not vary with time of day or activity level. Medical history is notable for fibromyalgia treated with pregabalin. She otherwise feels well and is active in physical therapy program. A physical exam, vitals are normal. Pitting edema is present to just above the ankles bilaterally without evidence of calf swelling, varicosities, or hyperpigmentation. There's no tenderness to palpation of the lower extremities. No JVD, extracardiac sounds, or pulmonary crackles are noted. So she seems to have like edema, but no signs of heart failure, or no scary signs of blood clots, or really any significant venous stasis over time. So which of the following is the most appropriate next step in management? Do you begin a diuretic? Do you do a Doppler ultrasound? Do you give her compression stockings? Or do you take her off pregabalin and put her on duloxetine? What do we think?
I would do compression stockings.
So definitely is like the least invasive here. So we should.
I'm not sure if pregabalin can cause lower extremity edema. Not to
That's exactly what I'm wondering. Can pregabalin cause edema? Then if that is the case, then we should switch. Otherwise, compression.
Yeah, so it's like one of those questions where you're like, you kind of have to know that. So we know B is not the answer because there's no concerning signs for a clot, and we know that diuretics are not the answer to peripheral edema, even though how often does this get done, right? But that's not, usually. So if we think it's simply like lymphedema or venous stasis kind of stuff, then compression stockings are it. here it's just like one of those things, and knowing that pregabalin or Lyrica works through a calcium channel blocker method. So it's kind of like your patient being on amlodipine. So like, your patient came in with bother of ankle swelling on amlodipine, you'd probably first switch it. But otherwise, if that wasn't in there, then you guys would be right on the money with compression stockings, right? Because that's like the least invasive option. But so when you're looking at the test, so least invasive options, so like PT, massage, CBT, but then also think, did we hurt this patient? Because this test, again, loves things that we do. And so this is us putting that patient on pregabalins. That's why that switch kind of is in there. But it's hard because like, this is like, if you don't know, that's a side effect. I don't think I really realized that pregabalin caused significant swelling until I wasn't attending, honestly. I've definitely seen it. Okay. Who wants to do this?
Definitely not me. I don't know anything about dressings.
Yeah, I mean, this is hard. So you have a patient who's got a pressure injury. It developed during a prolonged hospitalization after a motor vehicle accident that resolved in a closed head injury, pelvic spinal fractures. He's on heparin, oxy, ibuprofen, acetaminophen. On physical, his vitals are normal. He's got a painful 4 centimeter sacral ulcer with full thickness, loss of skin and adipose tissue, so stage 3, and no signs of infection, so no purulence surrounding induration. So what do you do? I would say like standard gauze dressings have largely gone out of favor. They're probably never going to be an answer to anything, just like dry dressings. We know that wounds favor like moist healing environments. We want it to heal from the inside out. I love how like all the things we learned about like wound care when we're younger, like I don't know, like everyone's telling you like put peroxide on wounds, use Neosporin and stuff, and it's actually like the worst things we can do for wounds. So like peroxide's like an irritant. Neosporin can cause like a contact dermatitis. So often, like dermatologists will just tell you to like wash your wound, cover it with like Vaseline and put a Band-Aid on it, right? So something like you're just providing like a moisture barrier and letting it heal from like the inside out. But like, I feel like the general public is, including us, is like just not doing the right stuff. So here, what they're going for is a hydrocolloid dressing. So it's just like, this stuff is going to stimulate healing by keeping the environment in a good place for the growth factors and stuff to go. I think the platelet-derived growth factor dressing and zinc infused is just like more specific stuff. Zinc tends to be antibacterial, so you might see that in things, but generally I think if there is a question on dressings with pressure wounds, it's probably going to be a hydrocolloid dressing, like something just very basic that's going to help them. And ideally, like if they're not asking you about dressings, what could they be asking you about? It's like behavioral interventions, right? So how do we prevent the patient from getting this, right? So this is why the nurses are supposed to be turning the patients every hour, and you're supposed to be getting the patients out of bed and all that kind of stuff to help prevent these from occurring. And then once they occur, I think another important thing for healing would be nutritional status. So making sure your patient's getting enough protein. I think those are all big like ticket items that could pop up in line with these questions. I don't think they're going to go crazy with every kind of a list of dressing, because I mean, honestly, we really don't do that. We're very spoiled here, right? We have great wound care. All right, who wants to do this?
A 29-year-old man is evaluated during a new patient visit. He is concerned about gradual weight gain over the last several years. He does not pay much attention to his diet and describes his lifestyle as generally sedentary. He does not use tobacco products and does not drink more than 1 to 2 alcoholic drinks per week. He reports no problems with non-restorative sleep or daytime hypersomnolence. He takes no medications. On physical exam, blood pressure is 149/90 and pulse rate is 87. BMI is 35. His waist circumference is 42 inches. The remainder of the physical examination is normal. Which of the following is the most appropriate test to perform next? Okay, so concerned about weight gain. He hasn't paid much attention to his diet. He's sedentary. No smoking, no alcohol. Okay, and hypertensive and elevated BMI. So exercise stress test, he doesn't have any chest pain, doesn't complain of any like dyspnea on exertion or anything like that. He's very young, so I don't think that's necessary. Hepatic ultrasound. Not an alcoholic. I'm not really sure why that would be, indicated. It's in this case. Overnight polysomnography, he doesn't say that he has problems sleeping, doesn't have daytime hypersomnolence, doesn't talk about snoring or anything like that. Serum lipid panel, and thyroid function studies, he doesn't seem to have any like specific symptoms for hyperthyroid or, thyroid dysfunction other than the gradual weight gain, but no other associated symptoms with like hypothyroidism, no hair loss, no skin changes, etc. So at this point, I would say, given that he has metabolic syndrome, obesity, high blood pressure, I would go with the serum lipid panel.
Yeah, exactly. So generally we say, I think the guidelines say like, oh, 35 to 40. But, if your patient fits metabolic syndrome, I think it's very reasonable to get a lipid panel, because we do see young people all the time with hyperlipidemia of some sort. I've seen it in like college students too, and like at some point it could also be familial. I think the big point here is like you ruled out A through C because they just do not make sense based on the patient's history, so there's no clinical indication for them. And then I think some people would be tempted to go with E, but the truth is it's like very, very unhelpful most of the time, unless your patient has got other overt signs of hypothyroidism. Because if the hypothyroidism is that bad to be causing such excessive weight gain and whatnot, they should have other symptoms present too, constipation, dry skin, lethargy, something else going on. Very good. All right, we'll do a couple, I think, eye questions next.
I can do this one. A
Oh.
61-year-old man is evaluated in an urgent care for acute frontal headache and pain in the right eye that began a few hours earlier while he was watching his grandson's baseball game. The pain extends through the anterior scalp and downward across the nose. The patient is also nauseated and vomiting acutely. He has photophobia and notes that light appears fuzzy. Medical history is significant for hypertension and anxiety. Medications are hydrochlorothiazide and citalopram. On physical exam, blood pressure is 150/90. Other vital signs are normal. Severe conjunctival erythema, photophobia, mid-dilated, non-reactive pupil on the right side, and corneal cloudiness noted. Upon gentle palpation of the eyes, tenderness and increased firmness are noted across the right globe compared with the left. Right eye visual acuity is grossly decreased. So I think it is acute angle closure glaucoma. It's got like headache and firmness, and his eye signs, mid-dilated, non-reactive pupil, is suggestive of angle closure glaucoma. Bacterial endophthalmitis is not like, it doesn't occur acutely. No systemic signs as well. CR vivo is usually painless. And scleritis, he might not have like headache and other associated symptoms, and we don't notice like firmness in scleritis. So I think it's glaucoma.
Yep, and this is, one of those eye things. It's a medical emergency. Patient can lose their vision in that eye. I actually, when I was a resident as a MAR, there was a patient that came in with this, but she came in the day later. So she actually like had this horrible pain, had worsening vision, like completely lost vision, and was like, I'm gonna go to bed. And then she showed up the next day. So we admitted her to medicine. We actually did what is that? Mannitol, IV mannitol. And so like Opto wrote their note, do IV mannitol to try to, like, they're just trying to put these salvage things. So I had to call a pharmacy because I was like, I don't know how to dose IV mannitol. Like what, we never use this. Needless to say, very sad, it didn't work. So like hopefully these people present and they get the acute care that they need. I think the big thing is like it's acute onset, right? Usually very painful with a headache, usually triggered like in the scalp by some light change, right? So they're like sitting and the light comes on early evening, or they're watching some TV, they're watching a sports game, and then they have a firm eyeball, and it's non-reactive pupil. Like everything else there, the pupil is going to be reactive, right? So definitely something not to miss. And then you just keep in mind that sometimes there's medications that can increase the risk of this. So I don't think I really realized that SSRIs possibly been associated, but like anticholinergic therapy certainly, as this has been seen here. Okay, we have another eye question. So the picture comes on the next screen. Who wants to do this one?
I can do it as well. 64-year-old man is evaluated in the ED for acute onset vision loss in the right eye, which began 1 hour ago. He can barely see his own hands in front of his eye. He has no eye pain. 1 week ago, he had an episode of monoocular vision loss in the right eye that resolved after 5 minutes. He has no other recent medical concerns. He has no history of floaters, headache, jaw claudication, muscle weakness, or weight loss. Medical history is significant for hyperlipidemia, hypertension. Medications are atorvastatin and lisinopril. On examination, vital signs are normal, loss of acuity, visual acuity in the right eye, and pupillary exam reveals afferent pupillary defect, optic discretion. Sounds like CRAO to me, central retinal artery occlusion.
That's a picture that you can see.
Yeah,
So what's key about that picture?
macular edema that I think.
So yeah, macular
Pale
edema. That cherry
area in the macular area.
Yeah, that cherry red phobia. So I feel like this is a picture that does like to show up on your test. So to be familiar with that. Also the venous hemorrhages that kind of cause that characteristic background finding. I'd say that's another one that can like show up on your test. Okay. What about this one? This might be our last eye question.
A 38-year-old woman is evaluated for a 2-day history of worsening eye pain and decreasing visual acuity in her left eye. The pain is worse with eye movement. She reports no fever or trauma. Vision loss is mostly central, and her ability to distinguish colors has diminished. She does not feel the sensation of a foreign body in the eyes. She wears contact lenses. Her medical history is otherwise unremarkable. On physical exam, vital signs are normal. Eye movement is intact but painful, with visual acuity of 2020 in the right eye and 2016 in the left. Apparent pupillary defect is noted in the left eye. There is no corneal injection or discharge, and the optic discs are normal. Okay, so she wears contact lenses, but she has pain with eye movement, and she doesn't feel a sensation of a foreign body. So I feel like with corneal abrasion, you wouldn't necessarily have pain with eye movement. Correct me if I'm wrong. And you would have
sometimes you can, like, if the object is still under the eyelid, you know, so in that case, like, you know, it's the traumatizing factor, the eye can just be painful, but you know, by the exam, you would probably see a corneal abrasion. If that makes sense.
Yeah, so she has an afferent pupillary defect.
And she has vision loss, right?
And she has vision loss. So I would go with an optic neuritis here.
Yeah, and so I think that, you know, thing to remember, optic neuritis, so this is like acute, painful vision loss. Usually in a young woman of childbearing ages, it's a hallmark, like, first thing that a lot of MS presents with. So anyone that presents with this, it doesn't have to be MS, but these patients all should be evaluated for MS. I actually saw this in our hospital as a medical student in an older man. So he was like in his 70s, and he came in with like acute bilateral optic neuritis. So he had like peripheral vision defects in both sides. And so he had this enhancement on the MRI, and his LP didn't show any signs of MS, but what he did test positive for was Lyme disease. And so, I mean, just one of more of those fascinating cases of how you can see Lyme, like neurologic Lyme, present. So I think that'll be very, just in case. That's not going to show up on your test. Here, this is going to be in a young female. It's probably going to be associated with MS. I don't think they're going to ask you to take it much beyond that. Okay, so now we have a 30-year-old woman who's evaluated with a 2-day history of sore throat and fatigue. She reports anorexia, chills, fever, rhinorrhea, and a dry, persistent cough that keeps her awake at night. She works as a school bus driver. She tried over-the-counter cough and cold products without benefit. Medical history is unremarkable. She takes no meds. On physical exam, her temperature is normal and her other vital signs are normal. She has nasal and pharyngeal erythema with sparse, whitish exudates. There's no lymphadenopathy or rash, and the remainder exam is normal. So how should we manage this patient? So they want you to know the Centaur criteria here, right?
Yeah.
She doesn't qualify for center criteria because she has fever and cough.
Yeah, so yeah,
Oh, sorry, not fever, cough.
Yeah.
right. She's got a cough. She's got other symptoms, right? So it's not just a sore throat on her own. She doesn't have lymphadenopathy. So how many of the Centaur criteria do you need to test?
You mean how many need to be positive or?
Yep. How many do you need for the guidelines to say that you should test this person with a strep
Oh.
test?
3.
I think 3, yeah.
3. So, this is another one where like, I feel like all these people that come to urgent care probably get antibiotics and a rapid strep test, but the guidelines specifically say like, if she doesn't have 3 Centaur criteria, you don't test them and you don't treat them for strep pharyngitis. So that, that takes off everything besides C, right, for this patient, because she doesn't meet those criteria. And then remember, the preferred treatment for strep throat is straight up penicillin. You can use amoxicillin, but it's not needed. And anyone with 3 Centaur criteria with a negative rapid antigen test, you could still send off a throat culture for them. And then we don't treat strep throat necessarily. If to treat strep throat, we treat it to prevent the delayed sequela, rheumatic fever. So you have time. I think everyone's like, oh, you got to treat this right now. I don't feel good. But truthfully, the antibiotics, I think maybe they show a mild improvement in symptoms faster, but it's not the actual immediate infection that we worry about treating. I think very likely too in these patients, like mono's on the differential. So like a mono spot test is like, very practical. Okay, what about this question?
A 24-year-old person is evaluated as an add-on patient for 1 week history of nasal congestion, watery eyes, and cough productive of yellow sputum. The patient is new to the practice and has indicated on the intake form that his gender is trans male. He responds to questioning that he would prefer to be addressed as he or him, but he seems nervous. He reports no fevers, chills, shortness of breath, or rash, takes no medications. On physical exam, vital signs are normal. There is oropharyngeal erythema and nasal turbinates are boggy. No tonsillar exudate or cervical lymphadenopathy is noted. Lungs are cleared, auscultation bilaterally. Which of the following is the most appropriate next step in management at this visit? I would just do symptomatic treatment.
Yeah, and I think that, the biggest thing we're saying here is that like, gender identity and all that stuff doesn't really, obviously it's not that it doesn't matter, but you're going to treat every patient the same. So this is just a patient that's coming in for an acute visit. Sounds like they maybe have like allergic rhinitis or something like that. So, you don't really need to do anything crazy, right?
Yeah.
Yeah, I can do this one.
Okay.
A 26-year-old man requests genetic testing for familial adenomatous polyposis. His asymptomatic medical history is unremarkable. 34-year-old brother recently underwent genetic testing and revealed a mutation of the adenomatous polyposis coli APC gene. His father died of colon cancer at 45 years, and 2 parental uncles died of colon cancers at 46 and 47. There is no family history of colon cancer in the maternal family members. He takes no medications. So, refer as he has like, we shouldn't do colonoscopy at 40. It should be much earlier than that. Like, it should be 10 years before the first like diagnosis that is out. And we have to send for like genetic counseling.
Yeah, so I think you can kind of narrow down between C and D and this kind of stuff we talked about yesterday. It's like these people always have to have genetic counseling before you go for genetic testing. So it's just kind of like remembering that rule of thumb. And so if he does, here, the nice thing, not that you want this to be running in your family by any means, But like, you know, the gene in question, so you can specifically test for that gene and counsel for that gene. It's not like you have to go crazy on gene panels and try to figure out what exactly the risk is. All right, so here we have a 70-year-old male who's evaluated before discharge from the hospital after treatment for pneumonia. His history is significant for mild dementia. He lives alone and has a daughter who lives nearby. Remaining in his home is very important to him. The care team recommends that the patient be discharged to short-term rehab to gain strength and prepare him to safely return home. The patient refuses. Decision-making capacity is assessed. He's able to articulate the risks, the benefits, and alternatives to short-term rehab, as well as an understanding of his current medical condition. So what is the most appropriate thing to do for him? What do we think?
Home care services, because it looks like he has capacity.
Yeah, exactly. So you remember that, you know, decision-making capacity really should be evaluated on a decision by decision basis, you know, so, and the big thing is that they're able to explain their medical condition and they understand the risks and benefits of all their decisions, right? So if they can say like, yeah, I don't want to go to rehab, but I know that I might fall at home and I might do worse. And if they're able to articulate that, then, you know, it's a free country. They can do what they want. Hopefully, you know, they can set them up safely at home. But remember, like the MMSEs are probably not going to be reliable inpatient. They should be done on an outpatient basis and kind of monitored over time. You know, you're not going to ask the daughter healthcare proxy to make a decision for a patient that has capacity. And other stuff is just kind of like very extreme. And then remember, just the MMSE and MOCAs in general don't assess capacity. The capacity really has to be, do you understand the question? Do you understand your condition? And do you understand the consequences of your decision? And if they're able to verbalize that, then you're all good. You don't have to agree with it, but if they can, you know, if they understand the risk benefits, that's all you can do. Okay, so then we have a 62-year-old woman who's admitted to the hospital for pneumonia. Her history is significant for a stage 1 estrogen receptor positive invasive breast cancer, which she was treated with breast conserving surgery and radiation and started on tamoxifen. During her hospital stay, antibiotic therapy is initiated and tamoxifen is withheld. Following discharge, the patient is evaluated in the office and it's noted that she's no longer taking tamoxifen. So which of the following measures would have most likely prevented this medication error? These are big errors we see all the time. That's why I feel like how many M&Ms have focused on this thought process.
MedRAC, medication reconciliation.
Yeah, whether we miss something going into the hospital because, you know, we don't have an accurate med list, so we don't give them something, and then sending them home, there's obviously been disastrous consequences there. And really the importance of a really good handoff and a discharge summary.
Just out of curiosity, Dr. Wright, do you have like a lot of questions left, or?
No, there's just a couple more left actually.
Okay, we can get through it.
I think but we can skip a couple because I will send my slides out, but let's go to the ones that are, I feel like, more high yield. We could do, like, these ones are more ethical dilemmas, which I feel like you guys can kind of go through those by yourself. And that's stat stuff. So that's, I mean, honestly, so this is really the basis of it. I can send you guys my slides, honestly, if you want to end a little bit early, because the rest of the stuff is mostly based on ethics and statistics and whatnot, which I think are a very low proportion of your test. And generally you can reason through because they're common sense stuff. But I'm happy to answer any questions or if you have any like concerns about a specific part of general medicine. I really do think, I mean, obviously I think this stuff is important because like I do this day in, day out, but I really do think my test is very heavy on general medicine stuff. It might have been mine alone. Everyone's test is slightly different, but like I said before, like musculoskeletal GU stuff, and like you always get infection questions, which kind of cross the board with outpatient, inpatient. So hopefully this slide, do we just send them to you, Sanchari?
Yeah, you can send them to me, and I'll send it out to everybody. Thank you again for your time.
Yeah.
Thank you so much, Dr. White. It's really helpful for us.
I wish you I'll hopefully see you all tomorrow.
Yes. Me too. I really like this format, or I at least really like this format. I don't know if the rest of you guys have any.
Yeah, I really like how, I mean, I feel that I learned a lot in general medicine. We usually don't focus on some like screening aspects and also some conditions like vertigo, and also, I mean, many of the general medicine topics are, I feel they're pretty well covered in this board review session, and I really learned a lot. Thank you so much, Dr. White.
Good, good. I'm glad I can help. And if I can help you guys as you continue to study, you just let me know. Okay.
Sure. Thank you so much.
You're welcome.
Hi. Tamil gives you a thumbs up.
Thanks, Kamal. It wasn't easy.
Bye, Anderson.